All right, so welcome. So first we have Jeremy Suttles. Works as a community engagement and partnership coordinator at the VA Ann Arbor healthcare system. Mute some people. And completed his bachelor's degree from University of Iowa, master's at the University of Kansas, and then a master's of social work at the University of Michigan. Worked as both an educator and a mental health clinician. Clinical experience includes crisis intervention, suicide risk assessment, addiction, recovery care, outpatient mental health, emergency psych services, acute inpatient psychiatric care, group therapy, all of the above, training and education, and the treatment of adults and adolescents. Currently serves as the Department of Veteran Affairs Community-Based Interventions for Suicide Prevention Program. And this is the VA's public health approach to suicide prevention, combining clinical care with community partnerships to enhance suicide prevention and care. That was welcome, Jeremy. And then Matthew. So Matthew is the Community Engagement and Partnership Coordinator for the VA Ann Arbor Healthcare System, graduated with a Master's of Social Work degree in 2010 from the University of Michigan. Has been in the field since. Has experience in several areas, including related to mental health, including practice as substance use disorder therapist, mobile crisis clinician, ACT, assertive community treatment, team leader, and suicide prevention case manager. Matthew has always seen the value in community partnerships, working on an individual level with patients, and now uses his clinical experience to help guide community engagement work. So we welcome Matthew and Jeremy, and welcome to Suicide Risk Identification and Safety Planning.
Thanks so much, Rebecca. Well, I'm going to go ahead and kick us off. So you heard my name's Csre Tool, one of the Community Engagement and Partnership Coordinators at the Ann Arbor VA Medical Center. And with me is Matt, who's also a Community Engagement and Partnership Coordinator. Not here with us is Alyssa Harris, who I believe may be on the schedule as the person presenting today. Unfortunately, she's out, so Matt and I are going to be filling in. Before I get started, I just want to take a moment to note that suicide itself can be an intense and emotional topic. If you find yourself during the session feeling triggered, uncomfortable, or in need of additional support, feel free to take time for yourself to step away or connect with your own resources and supports. It's important that whenever you're talking about suicide, or even when you're working with patients with suicidal ideation, that you take time to care for yourself and recharge as needed. So Matt, next slide. Today's session is going to cover a number of topics, as you can see here. The majority of the presentation will be us reviewing tools, strategies, and resources that we utilize at the VA to address suicide risk and aid in suicide risk mitigation. Some of the practices we discuss you may already be familiar with or may already be implementing in your own setting. We hope that you'll be able to contribute to the discussion as well about some of those tools and practices that you're finding helpful in this area. Next slide, Matt. So just to get us started, we want to do a quick poll in the chat to see how familiar people are already with suicide risk management. So you can see on the slide, the options are A, for having little or no experience, B, for a few cases a year, C, if you're regularly performing suicide risk management or evaluation, and D, if almost all of your work is devoted to suicide risk management and care. Let's give people kind of a second to respond. Some A's and B's. One C, between C and D, okay. So some familiarity and a few experts in the room, but maybe some people who are interested in learning a little bit more about this, which is great. Matt, if you want to go ahead and move to the next slide. So now, just as a follow-up to the first poll, how comfortable are you doing suicide risk management? So A would be you're not comfortable at all. B, you have some comfort. C, you're feeling decently comfortable, and D, you're quite comfortable, or you can rate it based on your own anxiety. So kind of seems like people are kind of middle of the road, like some comfort, you know, feeling a decent level in there, but maybe some room to grow. So that's a good place to start. Matt, you want to go to the next slide? So why do we want to spend time talking about assessing risk? Why is it important? First, it's just good care. Risk management is a critical part of providing quality care to our clients or patients and helping identify strategies to improve their health and safety. Risk assessment and management is also person-centered and an individualized process, as each person has their own story, their own risk factors, and their own safety planning needs. By taking time to delve into issues of risk, we're likely to learn more about our patients' or clients' lives, hopes, needs, and challenges. And lastly, we want to know going into risk assessment that it can be a stressful and anxiety-provoking process. And that's both for the provider and for the patient or client. For this presentation, we're going to be focusing on the provider portion. We want to help share some tools to help you feel more prepared, more confident, and more present in those situations where suicide risk is identified. Next slide. So just briefly, wanted to touch base on the significant overlap of substance use and suicide risk. Next slide. The data you see here is taken from the VA's National Veteran Suicide Prevention Annual Report. The data shows that individuals with substance use disorder diagnoses have an elevated risk for suicide, and individuals with opioid use disorder specifically have some of the highest rates of suicide. So just another question to the audience in the chat. From your perspective, what are some of the reasons that people with substance use disorders or substance use might be more at risk for suicide? Stigma, absolutely, and shame. Not feeling comfortable being open, sharing about their substance use or seeking help. Other things that people have noticed in their own practice, feeling overwhelmed that it might never end. Scared of withdrawals, impulsive decision-making, going out of control. These are all great examples. And it sounds like all things that people have experienced in either practice or maybe like in their personal lives, things that they've seen or understand. And there are lots of possibilities for this overlap and this increased risk, including the idea or the reality that using substances may increase a person's vulnerability to act on those suicide thoughts, or that use of things like opioids may lead to things like accidental overdose or death, especially with the risk of opioids being laced with other substances such as fentanyl. Next slide. So this slide illustrates that point specifically. Opioid overdose deaths have been increasing in part due to the inclusion of fentanyl and other like substances. For those of you who may not be as familiar, fentanyl is a synthetic opioid. It can be manufactured pharmaceutically or illegally. It's up to 50 times stronger than heroin and up to 100 times stronger than morphine. Fentanyl is often cut with drugs like heroin to increase the potency and effect, and it also makes the drugs cheaper, more addictive, and more dangerous. So one of the takeaways as we move into this presentation and talking about risk assessment is that we want to consider factors such as substance use and how it might impact a person's overall risk. Next slide. So now we're going to jump into some specifics about suicide risk assessment. We'll start with the caveat that there is no one way or no perfect tool for suicide risk assessment. There are many instruments and tools out there, many of which gather similar information to the ones we'll be sharing today. For our work at the VA, we've chosen to standardize our suicide risk assessment tools and practices in order to improve the quality of care. Standardization allows for more provider training and familiarity, as well as helping reduce stigma associated with discussions about suicide, both on the provider and patient side. The tools we'll be outlining are standardized as well in our clinical practice guidelines and in line with the Joint Commission's national patient safety goals. Next slide. If any of you are already familiar with the VA, you'll know that we lean heavily into evidence-based practice models for care. For the purpose of risk assessment, we want to bring the best tools and practices to bear to help support our veterans.
Oh, Jeremy, I think you may have been accidentally muted.
All right, sorry about that. So with evidence-based practice, we're not trying to make clinician robots. While there may be tools or manuals that we utilize, it still allows for individual conversations, unique and complex patient-provider relationships, clinical judgment, and personal style. Next slide. So at the VA, we utilize a two-step process for suicide risk identification. The first step is our universal screening tool, which is the Columbia Suicide Severity Rating Scale, or CSSRS. And the second is a follow-up tool utilized when a CSSRS is positive. And that tool is our Comprehensive Suicide Risk Evaluation, or CSRE for short in VA acronyms. Next slide. So just as a quick poll of the audience, who here is already familiar with the Columbia Suicide Severity Rating Scale? Feel free to type in chat, raise your hand, just kind of want to get a sense of this. Is this something new to people or something that people have seen? Yes, yes, familiar. Fairly common tool and usually easily accessible. Well, for the sake of the training, I'm just going to go ahead and briefly review it. For those of you familiar, these questions are definitely going to look familiar. The severity rating scale consists of 8 yes or no questions focused primarily on the person's suicidal ideation or behaviors within the past 30 days. For example, over the past month, have you wished you were dead or wished you could go to sleep and not wake up? You'll see from the slide that the questions are standardized, scripted, and there's a guide for what to do if a person says yes or no to the questions. And it is possible that a person will not have to answer all 8 questions on the form, depending on how they answer. Next slide. And these are the next 4 questions. You can see the screening progresses to ask more detail about a person's suicidal ideation and behavior, including any preparatory acts. Question 7 asks if a person has ever done anything in their lifetime to prepare to end their life or attempt to end their life. And one reason for this is that we know that one of the best predictors of future suicidal behavior is prior suicide attempts or behaviors. Next slide. So a positive Columbia screening is any CSSRS where a person answers yes to questions 3, 4, 5, or 8. If a person screens positive on this tool, it's recommended that anyone, regardless of your practice setting, do a further evaluation of the person's suicide risk and engage in a safety planning discussion. At the VA, a positive CSSRS triggers the provider to then complete our suicide risk evaluation tool, which we'll start to go over next. But before we do that, I want to note that community providers and individuals can and should utilize things like the Veterans Crisis Line as needed to help support veterans who are identified at risk for suicide. The number is the same as the National Suicide Lifeline, but for veterans or providers who are calling, you can press 1 to reach the Veterans Crisis Line staff directly. Next slide. Now we're going to move into the more in-depth risk assessment tool that we use at the VA. And these slides will show the components of the tool. And you're definitely able to take or adapt any of the information that we share today. This is a tool that's already built into our electronic medical record, and our providers receive specific training on how to administer this. And we'll share some of that same guidance with you today as we move through this. Next slide. So the comprehensive suicide risk evaluation, unlike the Columbia tool, does not contain scripted questions. It also does not have to be followed in order from start to finish because it allows for provider discretion to approach the questions in a way that fit the setting, the patient, and considers things like timing and rapport. The provider is encouraged to approach this in a curious and collaborative manner during the process. Next slide. Ultimately, this tool is meant to give a narrative and a whole picture to a person's suicidal ideation or suicidal behavior history. The more detail that we can gather, the better we can assess for a current acute risk as well as chronic risk and better plan for safety. Next slide. So these are the guidelines of who can complete a Columbia and a CSRE at the VA. Our preference is always for a licensed provider to be utilizing these tools, but there are situations in which that may not be practical or possible. And we would encourage any agency or provider using these tools to assess what makes sense in terms of your own workflow or staffing availability when adapting them for your use. Next slide. Are non-mental health providers expected to complete the CSRE? Typically, no. Ideally, it is someone who's a mental health provider with some experience and training in the area of suicide risk assessment, but this can vary by facility. In some cases, it might be appropriate for an unlicensed or non-mental health provider to refer to a mental health professional on the same day in order to help facilitate this risk evaluation. So for example, if you're in a community clinic or agency and a person presents with suicidal ideation and there's no therapist or psychiatrist available or on staff, sending the patient to the local emergency room for further evaluation may be an option. Next slide. So the CSRE is required following a positive Columbia Suicide Severity Rating Scale. In outpatient settings, that means that the comprehensive risk evaluation is done immediately on that same day. The reason being that if a person identifies current risk, further evaluation must be made in order to determine discharge and level of care. If a patient or client is in a secure setting, such as a residential or inpatient unit, this evaluation may not have to be done on the same day if we can ensure safety, but it's always advised to complete the comprehensive risk evaluation and safety planning as soon as possible to help mitigate risk. Next slide. At the VA, providers have options to forego the Columbia scale and go directly to the comprehensive evaluation if they know that the Columbia will be positive. And with the CSSRS, there are some guidelines that we have at the VA on when it should be administered, such as on first appointments, new evaluations, or on an annual basis. But we don't have those same required completions of the comprehensive risk evaluation because it's dependent on a person's current risk status and presentation. Next slide. So for those of you who have already been doing biopsychosocial assessments or risk assessments in the past, these components are going to be very familiar. The CSRE covers current and past suicidal ideation and behavior, as well as identifying risk and protective factors. It also asks the provider to stratify the person's acute and chronic risk, and we'll show you that matrix here a little bit later in the presentation. Next slide. So these are going to move into some of the actual questions on the form, and again, things that you might be able to adapt in your own setting. This section goes more in depth into specific suicidal ideation reported by the patient and asks for details of the thoughts as well as how often and how recently they've occurred. We will also want to assess for the presence of intent to act on those thoughts as well as any preparatory acts. Next slide. When assessing for suicide risk, we also want to spend a significant amount of time discussing access to lethal means. Often, people immediately think of firearms when discussing lethal means, but it can also include things such as supplies of medications, materials utilized for strangulation, sharps, buildings or bridges where people might engage in jumping, or other items related to a person's individual ideation or history. Whenever access to means is identified, it's important to include more detail, including things like specific numbers, location, availability, and any current or available storage options. Next slide. When assessing for suicidal ideation, we also like to ask separate questions about a person's most recent thoughts and their most severe thoughts of ending their life. There may be times in which a person's recent thoughts were the most intense or severe, but it's not uncommon for a person to have had a history of more severe suicidal ideation in the past. The downside of tools like the Columbia is that it focuses on the most recent ideation and can really neglect prior ideation or severity of suicidal intent and behaviors in the past. Next slide. So this section asks for more details about that past behavior. Sometimes patients or clients may not be able to recall specific dates or exact details, such as, a number of pills taken in an overdose attempt, or the amount of time spent in an emergency room or on an inpatient unit. But any details that you can gather are useful, as they'll help give you a picture of the severity of the ideation, intent, and also any care or support received. It's also useful to inquire if the attempt occurred within a time frame after discharge or during an episode of care. Next slide. We document preparatory behaviors and acts in our records. These are actions that a person may take towards suicide, but which do not result in actual harm. Some examples here, such as writing a note, researching methods or means, or stockpiling medications. While any of these behaviors is concerning and places a person at elevated risk, we differentiate preparatory behaviors from specific suicidal acts for the sake of documentation and assessment. Next slide. Just like with past suicide attempts, you want to try to gather as much detail as possible about prior preparatory behaviors. Next slide. There is no perfect way to predict suicide or suicidal behavior. That being said, we have learned from practice and research that there are a number of risk factors and warning signs that can indicate an increased likelihood of suicide risk. Oftentimes, the patient or client is aware of some of their own warning signs, especially if they've had a history of suicidal behavior in the past. So asking a patient what kinds of feelings or thoughts happen when they have suicidal thoughts, or what leads to suicidal thoughts, can provide important details in understanding their current trajectory and risk. Next slide. The CSRE tool that we utilize has a number of built-in boxes that can be checked in regards to predetermined or common warning signs. Some of the common ones are noted here, including suicidal communications or statements, feelings of hopelessness, increased isolation, or escalating substance use. But it also allows for additional warning signs to be entered that the clinician or patient have noticed. Next slide. And so this is a place where it can be helpful to document the warning signs that the patient is aware of based on their own history or their own self-awareness and understanding. For example, a person might say that they start ignoring calls and texts on their phone, or maybe they start yelling more at their pets. Warning signs can be very individual, and it's important to get the patient perspective as part of this collaborative process. So now I'm actually going to turn it over to Matt, who will pick up from here and go through the next part.
Okay, thank you, Jeremy. I'm going to go ahead and break script for just a quick minute here, because at the beginning I saw a lot of A's and B's as far as familiarity with some of this. So this is a lot of information we're throwing out. So I just want to pause for just a second. And if you want to throw anything into the chat, or I don't know if folks can unmute Rebecca, if they're able to. They can, it looks like, just to see if anybody has any questions or comments about anything that's been discussed up to this point.
Yep, go ahead and unmute if you'd like to speak your question. Otherwise, go ahead and put it in the chat, and we will have time for questions at the end as well. Youth. That's a good question. Do you know if these tools can be used for youth?
Yeah, so from what I understand, these tools, as far as the comprehensive and the Columbia, I believe, and if I'm not mistaken, Jeremy, correct me, were primarily used with adults. So I'm not sure if that does translate, but I'm not entirely sure. That could be something we could put in the parking lot and maybe get back to hopefully by the end of this training here.
And Yvonne, yes, we can get you the slides, I believe, and it's also being recorded. So you will get a recording as well.
Okay. Hearing no other inquiries at this point, feel free to also drop it in the chat at any time. We can go ahead and definitely get to it as soon as we get a minute. So I'll go ahead and kind of keep us moving here. One thing that just kind of came to mind as Jeremy was talking, the use of any of these tools, I think this has really been documented too in some literature. The use of any suicide screening tool has been found to be also very, very contingent on the approach that the person uses as far as the therapeutic approach when administering these tools. So I just wanted to put that out there as a reminder. And it really just kind of makes sense. You know, if somebody shoots into a room in an emergency department setting and shoots out a bunch of questions without really sort of bringing an empathetic approach, you may not get the most forthcoming answers. So I just want to put that out there as a reminder, is just to be very aware of our own approach when we're asking these questions, as that tends to be the most significant thing in using any of these tools. So just keep that in mind as we kind of go through this. I'm going to go ahead and talk a little bit about risk factors. We'll continue the conversation with that. And the way to sort of think about risk factors is, you know, these are the things that sort of, you know, increase the risk of suicidal behaviors versus the warning signs are sort of the immediate signs that there's trouble. So what Jeremy just covered would sort of be like the times that people would go to an emergency room if they were having, you know, heart pain, chest pain, you know, high blood pressure, all the warning signs, the immediate things that would give an indication of problem. Whereas the risk factors would be, you know, maybe the unhealthy lifestyle, maybe not exercising as much, not getting to the gym, you know, all those sorts of things, you know. So with that being said, we've probably also heard stories in our lifetimes about our family members or friends who have engaged in maybe some very unhealthy things throughout a lifetime and never developed a problem of any sort, health-wise or whatever it may be. So I just want to put this in here sort of as a precursor to what I'm going to discuss, is that a lot of folks can show risk in a lot of different ways and never go on to attempt suicide or to engage in a type of self-harming behavior. So these are things to think about. These are things that would give indication that future problems may come, but they may never manifest. And it's just important to know. So with risk factors, these are the things that increase the likelihood, but these are not guarantees. Some of these things include a history of inpatient hospitalizations. One thing Jeremy mentioned as another risk factor would be a prior suicide attempt would be another risk factor. Probably the number one risk factor as far as future behavior goes. Any psychosocial issues, legal issues, immediate access to lethal means, medical and psychological conditions, particularly chronic medical conditions, which really impede or impair a person's ability to function, and then also reasons for dying. So further, consider the long-standing characteristics that inform acute and chronic conceptualization for risk. So these are things that we can't change sometimes. These are perhaps childhood past experiences. Think of ACEs. These are some other static types of things. Could be, again, chronic medical conditions, mental health conditions. These are also things that would indicate risk. And some questions you can ask to identify some of that is, what are some problems that you experience in your life that are stressful? What are some reasons that you want to kill yourself? Or if there maybe was a suicide attempt, you know, what were you hoping to, you know, accomplish by ending your life? Well, I wanted to get rid of this pain that I'm in 24/7 or whatever it may be. You can find some really interesting answers to some of these questions. Gives an indication of where that person's thinking is, and to see and screen for if there's any things that we can do to modify the risk depending on what it is. So some common risk factors include history of a suicide attempt, recent psychosocial stressors, as I mentioned before, access to lethal means, whether that be firearms, large quantities of medications, other available objects or means to that could possibly be lethal, history of mental health hospitalizations, psychological conditions or symptoms, history of non-suicidal self-directed violence, so that could be self-harm of any kind, cutting, burning, any significant life events, such as divorce, loss of a loved one, any of those would be an increased risk. We already covered medical conditions. And then also something to consider as well is being a part of any particular group that is at increased risk for suicide, LGBTQ plus, knowing veterans are at a higher risk overall than the average civilian population. So things like that you want to think about. Pre-existing risk factors, again, history of trauma, history of suicide attempts. Some of these things may be available in the electronic medical record. These may be available for you already without having a screen for it. So that's definitely things you want to look at. And then on the flip side of the risk factors come the protective factors. So these are the things that, again, do not guarantee that just because somebody has these protective factors, they're not going to act on any kind of suicidal thoughts, but these are the things that decrease the likelihood that somebody would act on those thoughts. Some of these things include, actually I believe the number one protective factor is actually connection to another person that they trust. That is one of the biggest protective factors out there. Dr. Thomas Joyner does a lot of research into this topic, and especially with connection. So if that's something that you want to learn a little more about or look at, he speaks a lot about that. And that is definitely one that also pertains to youth as well. Having for youth a connection to at least one adult that they trust, that they can confide in, is a huge protective factor. So further beyond that, some things you could do to kind of elicit what are some of those protective factors, or asking questions such as, what are some things in your life that give you meaning, that give you pleasure, and finding ways to basically explore those and then also build on that. If someone has attempted suicide or is thinking about suicide, maybe they changed their mind, maybe they brought themselves to the hospital or to care. You could always ask them, what stopped you from acting on that thought? And that will usually elicit a good responses to a protective factor of some sort. I was going to, but then I thought about, what would happen if I died and who that would impact, or perhaps it was, for spiritual or religious belief. And these then start to open up conversations to additional protective factors that we want to try to build on. And there are several. This is by no means a elaborate list here. I think I'm going to get into it a little bit here. Here we go. Okay, there's my list. But let's move on to this one here. So reasons for living, person's self-identified reasons that are there for not attempting suicide. Another way to ask that question, what are some of the reasons that you're here and continue to overcome some of your challenges? And then these are some, thoughts about what could be some protective factors. Access, to healthcare, wanting to engage, feeling a sense of hope, motivation for treatment, access to an engagement with a mental health care provider. I won't go through this whole list here, but these kind of give us a good idea as to why, what could serve as protective factors. And that's really unique for everybody. So once we kind of get an understanding of the risk factors, the warning signs, and the protective factors, then we, through our CSRE that we've been talking about, we move to our clinical impressions, which at the VA, we try to stratify the person's acute risk and then chronic risk. And this kind of helps us to determine our disposition planning as to the next steps. So we look at, we'll get into, but easier if I just put it up on the screen here. So it's ranked as low, intermediate, and high, and that goes for both the acute risk and chronic risk. And this will make a little more sense here in just a second. So when we're looking at the first one here, this is acute risk. I know this is a busy slide. We're going to get into each one of these categories here in just a sec, so it'll look a little bit better. So starts out with high acute risk, moves down to immediate, and then low acute risk. So it gives some fundamental information about how we would identify this acute risk, what that would look like, and then also the action steps to mitigate that risk. So for high acute risk, this would be somebody who likely has a plan, has access to the means of which to carry out that plan. There could be some recent or ongoing preparatory behaviors. Maybe they've obtained their method of which they plan to use. Maybe there's been a suicide attempt, acute medical health symptoms, exacerbation of mental health or medical conditions. I mean, this is pretty straightforward. And as a provider, you're going to probably identify this one pretty quickly. And, generally speaking, when someone presents at high acute risk, chances are 99% of the time that's going to involve psychiatric hospitalization. So immediate acute risk looks a little bit different. Some of that presentation can look the same. So you may have somebody there who is presenting perhaps with suicidal ideations that are present and current and even have a plan. The difference may be that there's an ability there to maintain safety independent of external support or independent of an inpatient type setting. So there's maybe little to no intent to act on those thoughts. There are identified reasons for living. There's an ability and a desire to abide by a safety plan. And so this may also, indicate psychiatric hospitalization perhaps, but there's also the option here that somebody could manage this on an outpatient basis as well. And that could be through increased clinical care, good safety planning. We'll kind of talk a little bit more about that in just a minute. And then lastly, for acute risk, we're looking at low. So there's perhaps no current intent, no plan, no preparatory behaviors, pretty high confidence that, they would be able to maintain their own safety. And so there's not a whole lot here where there's going to be an indication that somebody is an immediate danger to themselves or others. There may be some suicidal ideation, but without plan or intent. And if there is a plan, it's likely vague, with no real thought into how to carry that out, no preparatory behavior or anything like that. So this could usually be generally managed in an outpatient setting, even in primary care, and mental health treatment may be indicated. So then we get into chronic risk. And this is where we look at, again, the same type of scale: high chronic risk, intermediate chronic risk, and low chronic risk. So what would be an indication of high risk levels as far as this goes? Prior suicide attempts. It could be chronic mental health conditions, substance use disorders, medical conditions that impact their functioning, limited coping skills, unstable or erratic psychosocial status, and limited reasons for living. This is also something that would look like any kind of stressful life event would really then, sort of turn somebody into more into the immediate or high risk, acute risk if something happened. So there's, generally routine mental health follow-up, safety planning, routine screening. These are the types of folks that at the VA we'd probably have on our high risk for suicide flag, which provides them with a higher level of clinical care, and then following as well, they get their own case manager and some other things. We'll kind of talk about that a little bit later. Intermediate chronic risk is sort of a balance between protective factors, coping skills, reasons for living, and their stability suggests that they can experience maybe some of these life crises without resorting to self-directed violence. Routine mental health care is there, usually present to monitor symptoms and conditions and maintain effective coping strategies. And then low chronic risk levels are, usually managing stressors without resorting to suicidal ideations. Usually there's an absence of self-directed violence or chronic suicidal ideation, or even a lack of tendency towards impulsive or risky behaviors. So this kind of gives an idea of how how we sort of stratify risk. And then as far as mitigating that risk, so basically any mitigation strategies for any of these identified risks, the mitigation should match the risk essentially. So the CSRE prompts providers to select from a checkbox of all relevant and appropriate strategies for the person based on the level of risk assigned. So for example, voluntary hospitalization, maybe lethal means safety counseling is a part of that risk mitigation, initiating evidence-based therapy, connecting them to other clinical care, engaging them in safety planning. These are all things that could be risk mitigation strategies. So this actually kind of takes us through some of the check boxes that we have to go through when we're doing this. And, it asks if we're creating this plan, this risk mitigation strategy with the individual's guardian, family, or additional healthcare providers, in what setting was this done? These are also some of the general strategies to manage risk, regardless of what the setting is that they're in. So one of the options here for us is to alert our suicide prevention coordinators. If we feel like this is a person who may be qualified for a high risk for suicide flag, that basically prompts our SPCs to evaluate their clinical presentation and determine whether or not that would constitute having a high risk for suicide flag, which would increase their clinical care. Also completing and updating a veteran safety plan, increased screening for suicide, providing lethal means safety counseling, obtaining additional information from collateral sources, from family, from friends. This is all an active approach to make sure that that person is doing well as they can, regardless of what setting they're in. So these are just a few of them. Now we're going to kind of look at, depending on the setting, some of the risk mitigation strategies. So if somebody's presenting on an outpatient basis, here's a list of some things here that could be warranted based on their presentation. So perhaps initiating a welfare check, calling first responders, initiating a hospital transfer, education as far as emergency services, who to call, where to go. Safety plan development is also a part of that. Perhaps making referrals to higher levels of care, maybe connection to mental health services if they're not connected with any of that. These are all options for outpatient settings. If someone is in a residential setting, again, I'm not going to read through all of these here, but there's a whole host of options here as far as what to do to mitigate the risk. There could be increased rounding depending on where they're at. There could be one-to-one staffing, perhaps. There's a lot of different options that occur in residential setting, same as inpatient. So there's all sorts of precautions and protocols that, depending on the person's risk, can be implemented on an inpatient setting. But lastly here is emergency department, so one-to-one, involuntary hospitalization, voluntary hospitalization, pretty straightforward as far as risk mitigation goes. Safety planning is one that, the VA really emphasizes no matter what. This is a good practice, and we'll talk a little bit about that here. So at the VA, this is to be done by the licensed independent practitioner or clinician, with the individual as a tool for risk mitigation. So safety planning, of course, should always be done with the person you're safety planning for and with. Printed copy should be given to the individual to keep with them as a tool to use when experiencing increased mental health symptoms and thoughts of suicide. Furthermore, now that everybody carries phones, there's lots of apps that are available. One that comes to mind is the PTSD app, which you do not need PTSD in order to download. It's free to everybody. And not only that, but it's an excellent overall mental health coping app. And you can also keep a digital version of your safety plan on that as well too. So it just makes it more accessible, but you definitely want to make sure that who you're working with gets a copy of that safety plan. And then naturally, the clinician should also keep a safety plan and even ask about updates as treatment progresses, and reassessing risk when you're working with that individual. One thing to mention, there may have been, at a time in history where, no suicide contracts were in effect, as practitioners were using that. One thing we're going to say is just don't stay away from them. We don't use them anymore. There's a lot of evidence to show that, they're just not effective. Safety planning is really what you want to do. And again, the quality, not just doing the safety planning, but the quality of the safety planning and really taking the time to ask, questions and to elicit answers. Because we've all been there perhaps where we try to do some safety planning and we get some one-word responses, and sometimes it's all we're going to get. But a really thorough and really thorough and elaborate safety plan really makes a difference. So in regards to the effectiveness of safety plans compared to the past no suicide contracts, there was a 76% less likely chance that someone would attempt suicide, and they also demonstrated decreased service utilization. So, there's all sorts of issues with the no suicide contracts. I'm pretty sure nobody's doing these anymore, but it's always something we have to put out there. And there's a whole host of reasons why they aren't being done anymore. So I won't get too much into the weeds about that. Safety planning is the way to go. So just kind of a brief sample of a safety plan from what the VA uses here. First step is really kind of taking the time to identify what are some of the triggers, what are some of the risk factors and the warning signs that somebody experiences, and what they would notice that would give an indication that things aren't going well. So this is a place where Jeremy kind of touched on earlier about what that would look like. Again, this is something that could go into the safety plan, and I would just say take your time with it. Really ask a lot of follow-up questions. Maybe ask about past times where somebody became acutely suicidal, if that was the case. What was happening before, what was going on prior to that, and get some good ideas about what to put into this first box. Because once somebody can recognize that, they can move to the second step, which are all of the things that they can do to cope. So things that help, what are some things that distract yourself, things that would be safe to do, and really build on this as well. So, dry the well on these questions, keep asking and keep, open-ended questions about all of these parts is important. We really want to kind of get as much as we can down on these safety plans. The better the safety plan, the more effective it is, the more elaborate it is. Third piece of this is people and places that provide support. So who is the person you can talk to, number one person that you can reach out to? That's my person. Great. Who's the next person? Well, that's really all I talk to. Well, what about if it's 3 a.m. and that person is sound asleep and you're not going to be able to reach them? Who's next on the list? I don't know. Well, let's put in the crisis number. Let's put the 24/7 crisis line on there. So we definitely want to build, again, on this piece as well too. Are there places that you can go and things that you can do that help you feel better? Get that all down. Build on this as much as possible. And then moving to step 4, family members or friends who may offer help. Let's get their numbers down. Well, I got their number programmed in my phone. Well, your battery might be dead. Do you have all your numbers memorized? I know I don't. So let's make sure we get their number down. As we mentioned, this is something we'd want to print up and give to them as well to carry with them in case they need it. Professionals, other agencies that we can call for help. Definitely, hey, I have a really trusted therapist who I can call and talk about anything to, or doctor, or priest, or clergy, or faith-based group, or whoever. Definitely put that all in there. And then step 6 really focuses on how to keep the environment safe. I know everybody here is probably interested to some degree about this topic, as far as suicide risk mitigation. We're doing another one coming up in a little bit here on lethal means safety, where we kind of do a very more in-depth discussion about what this is and lethal means safety, and how to a lot of more information about it, which I think is really, really helpful. So talk about ways that they can keep their environment safe at home. So I'm in recovery, but I'm really feeling on edge. I do keep some alcohol around the house for guests. Well, maybe we could talk about how to make this environment a little less tempting if you're going through a crisis. And as far as safety goes, then we can look at having medications maybe with family. Maybe we could say, hey, I see you get 30 days of scripts at a time. How would it be if if you had somebody you trust to hold on to your medications while you're going through this, just temporarily, until you feel a little bit safer, more comfortable with having that in your house. So there's lots of ways to talk about how to make the environment safe. Questions you can always ask are, are the things in the home that you feel could potentially be hazardous to you if you're in a crisis. Well, I have 20 bottles of expired medications in my cupboard. Okay, well, let's talk about maybe how to make this a little safer. What are some things we can do? So there's lots of ways to have this discussion, but it is an important one. And as we talk about in our next presentation, the time at which somebody decides to take action to a suicidal thought, from the time they have the thought to the action stage, is less than an hour, and generally 50% of the time less than 30 minutes. So if somebody doesn't have immediate access to something lethal, it goes a very long way to promoting a good outcome. So that's something to think about. So I am stressing this part here because it is very important, as all of it is, but having a safe environment makes a big difference as far as risk goes. All right, and one thing I don't think I mentioned is, if possible, with the consent of who you're working with, definitely always ask to involve family, friends, guardians, caregivers, whoever it may be, to be involved in the safety planning process. It becomes that much more effective as well. So is there somebody we can kind of, hey, this is a great plan, this looks wonderful, let's go ahead and see what we can do to can we share this with your caregiver, just so they have a heads up as to what we've talked about. And so anytime you can involve family or friends, they can also even be a part of the safety planning discussion if you want. And with that being said, we can ask some of those questions to whoever is present as well too. What are things you notice when things are starting to go downhill or not going well? All right, so that is, in a nutshell, safety planning. I'm going to move to just some resources here. And Rebecca, remind me, do we have until 11:50? Is that correct?
Correct. We have time for questions.
Okay, good. So we got 12 minutes. So I'm just going to get through these resources here. One great resource is suicide risk management. Is there for anybody, any provider in the community working with a veteran. If there's any questions about risk assessment, lethal means safety counseling, best practices, how to engage veterans that are at high risk of suicide, regardless of whether they're receiving any care or any benefits or anything with the VA, this is available and open to any provider in the community. So you can email them, reach out, and they will provide you with any support that they can give you as far as any of these things here. So that's kind of a neat resource that they have for the community. And just some general resources: American Association of Suicidology, American Foundation for Suicide Prevention. These all have great resources on their websites and information related to kind of what we talked about today. There's also the Suicide Prevention Lifeline for loss survivors. Of course, the 24/7, National Crisis Line, 800-273-TALK-8255. Coming soon to a phone near you in July 2022, they should be rolling out 988, which is going to replace the big 800 number for the suicide prevention line. I should say it'll maybe not replace, the 800 number will still always be in existence, but they're moving to the 3-digit number to make it a lot easier for folks. And a lot of things have indicated that call volumes increase quite a bit with that. So that's a good thing. It's easier to remember, similar to the 911 system. So that'll be coming out hopefully here in July 2022. Some other additional resources include Lifeway CMH, the local county crisis services and mental health access number is there. Henry Ford Allegiance Emergency Department is listed as well. And then these are just some of the community coalitions that exist locally there, including the Veterans Hillsdale County Coalition, Drug Free Jackson, Jackson County Suicide Prevention Coalition, Southern Michigan Female Veterans Prevention Works in Hillsdale, and the Suicide Prevention and Governor's Challenge Initiative, which is called the Michigan Governor's Challenge. These are all great resources here. So kind of getting to the end, there is a quick little poll here. I'll just throw it out. And I know this is a lot of information, but let's see where we're at now. So as far as comfort with risk management, suicide risk management, having a better understanding of that and the mitigation and how to identify and safety plan and all that. Let's see where we're at now. A would be not comfortable at all, or maybe even more anxious than you were when you started. Hopefully it's not the case. Some comfort, but feel less anxious throughout. Let's see where we're at here. Okay, wow, a lot of C's. Decent level, but occasional. That's great. Awesome. I want to know the person who has the no anxiety in Part D, because this is where I've been for over 10 years, and there should always be a degree of anxiety. I think when we're having these conversations, it's healthy, to feel not 100% sure, because that's just going to help you make sure that we're doing as much as we can to ensure that someone's going to be safe. So yeah, I don't know if anyone ever feels 100% comfortable in these situations, and it's generally always anxiety provoking to some degree. So I'm going to open it up. If there's any questions, thoughts about anything that we talked about here, let us know.
Thank you very much for your presentation and coming in last second. All right, I'll get the questions in the chat or go ahead and unmute.
More than
The
welcome.
link is coming.
Yeah, this, Jeremy, just thinking myself, I don't know if you know the answer either, but is that, I wonder if these tools are shareable as far as CSREs, if, I know the Columbia is out there, but as far as the CSRE goes, do you know if that's a shareable thing through the VA too?
Yeah, it is. I don't think that there's an easy link to access it online, like through the MyRec, but I believe that it's something that can be shared. Obviously, people can take it directly from the presentation and adapt it, but also we do have sort of a long, basically a Word document of all the questions and options that people can utilize and access, and we can share that with people who might be interested. We'll probably won't attach it as default to the presentation slides, because the presentation slides contain all the information already.
I accessed it online already.
Oh, great. Good.
Awesome.
Glad it's out there. Thank you, Carol.
So here's that link that Jeremy posted earlier too. So it has that acute, chronic, therapeutic risk management levels. And also I saw the apps on there too,
Oh, good.
the PTSD one and Virtual Hope Box.
Yeah, and the
Yeah.
PTSD coach also has a way to input the safety plan digitally into the app itself. So it's something if people want to utilize. Sometimes we encourage people to take pictures of their safety plans. Again, if they have their phone, if their phone's dead, that's not as useful, but printing and providing a copy of this that they can store in their nightstand or their glove box or share with people, always helpful information.
So I'm curious about safety planning and involving family members. So is there a time when involving the family members is not helpful? Is it you safety plan and then involve the family members? How does that work? That makes sense.
Yeah, I'll be happy to jump in on that one. So it's a really good question. Sometimes, I think somebody's presentation could be possibly related to a stressor involving, said family member potentially, or there's times where, if we're looking at, situations involving domestic violence and someone's intimate partner, there's some situations there where you definitely have to be careful and explore with that patient, whether or not it is, going to be more effective to involve them or not.
Yeah.
But, that's definitely only with the consent of the patient. So I certainly would never want to ever kind of feel like, we have to obligate them to put someone in there and to talk with them. It's really a collaborative thing doing the safety planning. We're doing that with them and asking for their permission on every part of that. So only with their comfort would we ever involve somebody, whether it be family or friend in that process. Good
And
question.
I would add to that too, that, approaching suicide risk with sort of that curiosity can also be helpful. I've often found it to be helpful that maybe I'm working with someone who has family and they sort of by default put it down like, oh, my wife, I would definitely put her down. She's my family. But it can be helpful to ask those follow-up questions of like, well, what does she do that is supportive? Like, what has she done in the past to show that she might be a good support or might be a good family member to outreach, whereas other family members might be like, oh, my sister, like we've grown up together. I haven't talked to her very much, but I know she'll always be there for me. Some of those additional exploratory questions can be helpful in understanding the quality of the relationship rather than just defaulting to family being involved or being listed in the process.
Yeah, I like that. Yeah, take it curiosity. All right, any other questions, comments, or concerns? I did put the evaluation in there for your CEUs, as well as that link to download those resources from the VA. So with that, thank you very much again, and I will stop the recording.